Sedation. What I'm going to talk to you about what the current sedatives are available, when they should be used, or roughly when they should be used, and the why was really I was thinking about new advances recently in sedation. Why don't we just wake our patients up instead of keeping them deeply sedated when they're ventilated? So, sedatives, I think it's really important to remind ourselves why we use them, and then what some of the adverse effects that we see all the time. It's not necessarily what we want, but it's something we've just got to accept it's with them. For ventilation, we use them for toleration of the ventilator and for anxiolysis. What we often see is their somnolence, deep somnolence, and a lot of them have amnesic properties. We used to think a long time ago that was very desirable, but I think now patients find it quite traumatic, particularly those that have been ventilated for weeks on an intensive care and they've lost long periods of their life. They also suppress REM sleep, the benzodiazepines do. So one of the reasons I think patients get very agitated when they're waking up is we've suppressed their REM and they get lots and lots of rebound REM. And I do quite a lot of patient counselling and talking to patients with my nursing staff, explaining to them these vivid dreams they get as part of the sedative and not part of something in themselves. We have benzodiazepines, lorazepam, midazolam, which of course we use much more frequently than we'd like to. Also Propofol, an excellent somnolent, but not without its problems. And lastly, we've got the newer agents now. One very old agent, clonidine, which is an antihypertensive, which happens to have some sedative properties, and dexmedetomidine, which is actually, developed for its cause, or I like to think so. So the benzodiazepines. Thinking of midazolam. Midazolam, when it first came out of the ICU, was really perceived as the ideal agent. Very short onset of action and perceived short half-life. The original text said it has a predictable metabolism and it had no active metabolites. Well, back in 1988, a chap called Oldenhoff looked at the pharmacokinetics of midazolam in about 11 patients, and he found a huge variation in serum levels. He also found very little association between the serum levels and the actual sedative effect. So, i.e., you can't really predict how much to give and what kind of sedative effect you'll get. He also noted, many of the earlier papers said that the glucuronide metabolite had no action, but what he noted was there were a couple of patients who were deeply sedated with no midazolam detectable, but with high levels of the glucuronide. And it took about 7 years later, and 7 years for, actually when I started in ICU, to try and save some money, to switch lots of patients from Diprivan, which was then a licensed product and very expensive, to midazolam. And I always say I spent the rest of my career trying to reverse that. In 1995, a group in Basel found that they looked at 6 patients in renal failure in the ICU. And this was a real advance, and this really concurred with what we were seeing in therapy, was that patients in renal failure were accumulating the glucuronide. It had sedative effect. They did some binding work with the GABA receptor, and they found it had an affinity about 12 times less than midazolam, but was present in very high quantities. And so they concluded from this that the glucuronide actually had pharmacological activity, and midazolam should be avoided in those patients with renal failure. And then a wee while later, of course, there was the best paper of all coming out of Guy's and Thomas's, when we actually measured the levels of midazolam and the glucuronide, and we proposed that this was often confused with neurological insult in the ICU. And what we found was there were some patients that with poor cardiac function, renal function, who had midazolam in theatres or just after, and we could still detect it in their serum days and days, up to about 96 hours after cessation of therapy. And I think this really made us conclude that midazolam should really be reserved for the younger, fitter patients, and really avoided in those patients who are elderly with globally impaired cardiac function and renal function, because it will accumulate, the patients will get oversedated. Often these patients have 1 or 2 windows for extubation, you then miss that window. So, just to remind ourselves why midazolam's got this 2-stage metabolism, and of course if you went back and looked at it, you would have thought we must have some problems over sedation. It's metabolised by CYP3A4, tons of potential for interactions. to the active metabolite 1-hydroxymidazolam. It's then a 2-stage to the glucuronide, which again has pharmacological activity. So, shouldn't we all switch to lorazepam? Only 1 stage of metabolism in the liver, produces lorazepam 3-glucuronide, and actually it's so metabolized by this glucuronide that you can actually measure the liver's rate of glucuronidation by looking at lorazepam. So, ideal agent. We know that the lorazepam 3-glucuronide has no pharmacological activity. And actually, it's available enterally, which is very nice. You can give it sublingually, and you can give it parenterally. And at that time, actually, in Thomas's, we actually switched a lot of patients to lorazepam infusions. There were a couple of patients came out of the US where they compared lorazepam to Propofol and to midazolam, and they concluded not only was it more cost effective compared to the midazolam, there was shorter mechanical ventilation, and it was just all round a very fab agent. And in 2002, I think, Judith Jacobi recommended in America that everyone should change to lorazepam, and this was a real shift in therapy in the US, and very large lorazepam infusions were employed, much larger than were ever used in the UK. So what went wrong? Well, delirium came along, didn't it? Defined, as we all know, as a brain confusion, and Waz Ely and his colleagues did a lot of work in this. It's found that delirium was an independent risk factor for increased mortality in ICU. Lorazepam was the most likely agent, and I put it to you, it was lorazepam in these very large doses as a very likely agent. Some of my intensivist colleagues don't quite agree, they think it's any dose, but I think it's a very large doses. Most likely agent was lorazepam, then fentanyl, then propofol. What I couldn't work out, and what I found very hard, was why lorazepam? Why does lorazepam cause delirium? If you look back, actually, in the 1980s, lorazepam was used a lot then. It was Ativan, and it was dispensed a lot and prescribed in general practice. And there was a big campaign to stop it being prescribed because you got this agitation with it, and you got acute withdrawal. And that's related to its potency, so it's very short-acting, and it's this very short, quick offset as well, because there is no active metabolite. So patients who have a potential to be agitated, the drug wears off, they then became very acutely agitated. And actually much earlier than Ely's work, there was another group who looked at withdrawal in the ICU, and they saw withdrawal symptoms after lorazepam therapy and after the short-acting opiates. So what I think is the critical care delirium picture is probably mixed. It's probably a little bit of delirium, but it's also drug withdrawal as well, I think. And I think it's very important to remember it's both. And lastly, this phenomenon that they saw in the US was in the very large doses. And when, I can never say his name, I think I spelled it wrong there, Pandhydropandi, is that right? When he actually looked back, it was doses over 20 milligrams per day. So I think smaller doses, as an adjuvant, you probably get less delirium, but it should always be used with caution. So that was the benzos out. What about, and just quickly about treating delirium, the problems of in the ICU is you need a calm and familiar environment, and of course we don't grow up in ICUs. It's important to restore the sleep-wake cycle. That's just really difficult. And actually what we normally do is resort to antipsychotics. First line for a long time was haloperidol, but recently there was the HOPE study, Valerie Page and colleagues, who used early haloperidol, didn't need to prevent delirium, and I think it had no effect. Yeah, that's right, and quite over-sedation in the haloperidol group, yeah. There are, of course, other agents you can use. There's olanzapine. It had one study, it was at least as effective as haloperidol. And then myself and some colleagues looked at quetiapine, and we think that's quite effective. All we have is case series, though, and we really need to do a controlled study against haloperidol. But the point is, delirium doesn't need probably drug therapy, but in the ICU it's very difficult, I think, in an acutely agitated patient to not employ it, particularly if they're becoming a risk to themselves and nursing staff. It's even more difficult when they're obese, and that's a real challenge for delirium in the ICU, because the nursing safety and the safety of the health professional really is a big factor. So, we could just use Propofol for everyone, nice and safe, excellent somnolent, really good at putting people to sleep. Of course, that's what's used a lot in theatres. Not sure if it's an anxiolytic. It certainly reduces our perception of pain. Short-acting, doesn't accumulate in multiple organ failure. It's metabolised to glucuronides, and none of them have any activity. It's particularly good, therefore, in liver failure, because we can always metabolise phase 2 drugs. But is it as safe as we think? Well, there's a case series written from Queen Square where they were using very high doses of Propofol, and what they found was they had a series of sudden cardiac death in their patients, and they looked back and reviewed, and they found an association between that and high dose Propofol. So really, there is this risk of Propofol syndrome, sudden cardiac death. I think it probably should be used in maximum doses of 5 milligrams per kilogram per hour, and consider risk factors like high serum triglyceride levels in patients who may have a propensity for it. I find in practice the sudden wakening from Propofol can be very difficult, particularly in the patients who are in ICU for a longer time. I think when it's used for theatres, you're put to sleep, you wake up, it's fine, but if you've been in ICU for 10 days, you then wake up, it's not surprising that the patient will become very agitated. And what we find sometimes when treating agitated patients is this on-off effect of Propofol is actually very difficult, very deleterious to the patient. Other adverse effects, of course, is this reduction in blood pressure, reduction in cardiac output, particularly seen in patients with heart failure anyway, or in the presence of an alpha-2 agonist. So, opiates. I mean, just to, of course, remind ourselves, we use them for respiratory depression, antitussive effect, synchronicity with the ventilator, and somnolence. And there's a whole variety. There's a variety: alfentanyl, fentanyl, the short-acting synthetic opiates, remifentanil, diamorphine. There was one unit in the UK still using it. I don't believe they are anymore. Oxycodone. We find oxycodone now unit very helpful as a substitute for patients on long-term short-acting infusions like long-term fentanyl. And of course, there's methadone, which we used to use a lot of, but we don't do so much now, because I think we measure people's QTC, and we're always a bit scared of the potential for interactions and prolonged QTC. So, what about morphine? Well, this paper excited all the pharmacists. We loved this, because this was really one of the first papers that showed that drug metabolism was important in intensive care, and the presence of active metabolites was really important. There was a group back in 1986 detected morphine-6 glucuronide in the presence of renal failure, and they proposed that the half-life can be, extended from 4 hours to anything up to 24 hours. And given that more than 50% of our patients in the ICU have renal failure, it's a tough choice to choose morphine. The other agents, the synthetic agents, fentanyl and alfentanyl, actually there's little evidence of accumulation of fentanyl for greater than 48 hours. I had to do that as part of my PhD thesis and look back at all the literature. Of course, you get this pharmacokinetic maximum effect with fentanyl, and doses higher than about 600 mics per hour. You really have to switch to another agent. We like alfentanyl sometimes. It's a nice respiratory depressant, and you don't seem to get this maximum effect quite as much. Of course, what's also nice with these synthetic agents is neither of them release histamine, and that's very handy in the asthmatic patient. So what about remifentanil? I don't know, I think it's one of these it's a bit like dupexamine, really, isn't it? It's a drug without a cause. If you don't use very much of it, you find it very difficult to handle. It's very short-acting, no accumulation, metabolised with plasma esterases, so you switch it off, the patient wakes up. If you don't use a lot of it in your ICU, you stop it, you change syringes, patient wakes up, they can become very agitated. Those units that use a lot of it, I think, get on very well with it. Causes respiratory depression, of course, potent respiratory depression, bradycardia. We've had a couple of instances of patients we've bolused remifentanil by error, and we've had respiratory arrests in patients who weren't fully ventilated. So it's a drug to be used with caution. We now use it in very, very tight patient groups, those who really require frequent neurological assessments when you're very unsure. Those with spinal drains after what's it called? Aneurysm surgery, and type 2 respiratory failure, where you really have a very short window for extubation. Actually, those are probably better treated now with dexmedetomidine, come to think of it. And there was some studies, of course. The same group looked at remifentanil versus midazolam, and I can't remember what the first one was. The second one was certainly midazolam, and of course they had huge doses of midazolam and standard doses of remifentanil, and surprise, surprise, the midazolam group were all over sedated for days, and they then concluded that he was shorter ventilation in the remifentanil arm. I don't think MD really took those studies very, very seriously, given midazolam's pharmacokinetic properties. So, moving swiftly on the adjuvants, I'm not really going to talk about the adjuvants much, rather than to just say they're really important, particularly in longer term patients, and rather than going up on a dose of one agent, always consider adding something else in. But add something else in that's appropriate for that patient. Don't add in an antipsychotic when they're deeply sedated, because there's no way you can tell if they're delirious. I mean, I can't do the CAM ICU very much anyway. And, you know, I've tried to. Are you a fish, or what's it? Do you float, the stones float on water? I don't know. It's just very difficult questions. But adjuvants like lorazepam and clonidine as extras, I think, are very, very important in patients, particularly when you exceed the maximum dose of propofol or other agents. So, why not just wake them up? And what about arousal sedation? We know that high-dose propofol causes problems. Sorry, I've got to look around. I can't read it here. I can't read it here either, so I'll go in. Propofol and midazolam are both somnolents. Prolonged or over sedation is difficult. It's difficult to communicate with patients. And I think actually, I'm sure many of my nursing colleagues would agree with this, the best thing about awake sedation in the longer term patients is seeing them communicate with their families. We've got a young 20-year-old at the moment on ECMO who we've got on dexmedetomidine, and she's communicating with her family and communicating with us, and it's very, very nice to see. They all cause amnesia, as I said earlier, and that's not wanted often in patients. And there's evidence of benefit of awake sedation. There was Strom's study who compared, I think it was morphine and midazolam versus morphine alone, morphine boluses. The problem with that was it's really a study, I think, of midazolam versus no midazolam. And of course you're going to get benefit in the group that doesn't have midazolam, because they're not going to get over sedation. But nevertheless, this sort of concept of awake sedation is very interesting for intensive care and for ventilation. And so there's the alpha-2 agonists, there's clonidine. Evidence, well, it's been around a long time, and really there's not very much evidence for its use in intensive care. It's pharmacokinetics, as I said, there's very limited evidence. There's some with children. It has difficult adverse effects. You get hypertension, you get bradycardia, you get paralytic ileus, particularly in those patients with renal failure. And actually, I think you need very high doses for it to be effective. And I'm quite dismissive of it, I must admit. I don't think it's a great drug. Some of my colleagues quite like to give it a shot. And then there's dexmedetomidine, actually much more potent than clonidine. About 8 times as potent affinity for the alpha-2 receptor. It almost hypnotises the brain, they say. And when patients respond to dexmedetomidine, it's almost like they just look very chilled out, don't they? You often need a supplement agent, but they just look relaxed, and you can communicate with them. I think one of the problems with it is we forget that there are arousal sedation, and we forget we can communicate with those patients. We often treat them as deeply asleep, like they're on midazolam or propofol. So, dexmedetomidine, I think, was really important as a pharmacist to remember about it. Is actually it's the only agent with full license for sedation in the ventilated patient. Every other agent has a restriction on it. It's a number of studies of benefit. It's the Riker study, it was the SEDCOM study, then there was the I've lost my way now. Then there was a non-inferiority MIDEX and PRODEX study, which I'm going to talk about very briefly. How am I doing for time? Okay, thank you. So MIDEX and PRODEX are 2 phase 3 studies conducted over Europe. They're double-blind randomized placebo-controlled study. One study was, no, they weren't. One study was MIDEX versus midazolam versus dexmedetomidine, and the other study was Propofol versus dexmedetomidine. This study was really required for license of dexmedetomidine in Europe. I believe it's been licensed in the US for quite some time, hasn't it? Next slide. So the outcome measures, they looked at two primary efficacy outcomes. They looked at the proportion of time within a sedation score and duration of time in mechanical ventilation. And what they found, but secondary outcomes, which are very important in this study, was the length of stay in ICU and the ability to rouse the patient, so the ability to communicate with the patients. In the midazolam group, where's that thingy? Which bit is it this? In the midazolam group, there was shorter duration of mechanical ventilation with dexmedetomidine, and there was no difference in the propofol group. The visual analog score, which is really important, of course, as I said, it was patients receiving dexmedetomidine were more rousable, more able to communicate with nurses, more cooperative, and in every single part, every single question of this visual analog score, it was highly significant. So, what we were all looking for, and what this gets us very confused all the time, was this neurocognitive effect. We all wanted to see that the patients that got dexmedetomidine got less delirium. In the MyDex group, there was no difference in delirium. They did a CAM ICU score. I think it was 24 hours after the end of the MyDex or Prodex infusion. There was no difference. But in the propofol group, there was a reduction in delirium, or this neurocognitive effect, in the dexmedetomidine group. Patients receiving dexmedetomidine required less adjuvants. And in both groups, the need to reinstitute sedation was the same. That's not really surprising, because they probably reinstituted sedation for some, deterioration in the medical condition. And in the MyDex group, the midazolam group, they only did the CAM ICU once, and it was at 24 hours. Now, the patients who were on midazolam must have been deeply asleep, because half of them wouldn't have woken up anyway. So I'm not sure that should they have done it later, like they did in the SEDCOM group. I think SEDCOM study, they would have seen much more effect. So the conclusions was dexmedetomidine was not inferior to propofol or midazolam. It appeared to shorten the time of mechanical ventilation in the midazolam group, but not in the propofol group. Surprise, surprise. And patients who received dexmedetomidine were much more able to communicate with nursing staff. So, what do we think? This is a real change for us in sedation in the UK. So it's really worth thinking about. What do we think about it? It was the first large-scale study to compare dexmedetomidine against propofol. It was a well-conducted study. The problem was that the fact that the patients who were more rousable in the dexmedetomidine arm could have been because they were more lightly sedated within their same RASS score rather than an inherent property of the drug. But this better ability to communicate with dexmedetomidine could facilitate early recovery, and it's certainly something we're thinking about, and longer outcome studies should be considered. So, we introduced dexmedetomidine, I think, about 3 days after it was licensed in the UK. Being very keen unit. But we do use quite a fair number of high-cost drugs at Guy's and Thomas's. But we do try and really be quite rigorous in our practice and review them. We do the same for levosimendan. In fact, we've just published our first case series. So what we did is we looked at our dexmedetomidine patients. We reviewed all the patients who received dexmedetomidine in the ICU over the last 6 months since licence, and we extracted data from pharmacy as well. And what we found is just over half of patients had some improvement. 12% required to be resedated, and about 30% of patients had no improvement on dexmedetomidine. And it's really this that we want to find out. We want to further predict which patients will be of benefit. What we do know, and this is from our study rather than from literature, is when it's effective, it takes about 1.3 days to have an effect, i.e., if you don't get any effect after 48 hours, it might be worth stopping and considering another therapy. The mean dose for response is around 1 mic per kilo per hour. That becomes very difficult again in the obese patient. And those patients require, we think they require very big doses. When you give them these doses to their body weight, they then get much more adverse effects. What is very important to consider with dexmedetomidine is the cost. It's not that the drug's that expensive. It costs about £200 per day. But it's just that all the other sedatives are generics and they're very, very cheap. So the cost of dexmedetomidine versus midazolam is actually about 10 times more. And really you've got to justify that within the ICU. The time to steady state is actually about an hour. So I put it to you, you should use it for about 2 days. If you don't see any effect within 1 or 2 hours, consider a change. It can be quite difficult to see that effect because when you start it, you're often weaning other agents. And don't give it at the same time as a large dose of Propofol, because Propofol is a somnolent and you're trying to wake the patient up. This is something we get confused about all the time when we're using it. So, when do we think, looking at our audit and the trials, it should be used only in short to medium term? Restricted for critical patients where anxiolysis or this awake sedation is really preferred, and that's often long-term patients, those patients on ECMO, difficult extubations. Oh, I've got the next slide already. I didn't think that thing worked. Can I go back here? ECMO patients who've been very long-term ventilation, who we like to communicate with, patients who we think will be a difficult extubation, that we want a drug that is not a respiratory depressant. And that's actually the group that we've had the most success with. We've had some very, very difficult patients. Guy's nodding, he had one of them, that we managed to extubate in dexmedetomidine. The hardest group is those that are at high risk of critical care delirium. Now, it's not patients that are delirious already. It's those that you think might get delirious. And if you can get in on time, you often see an effect. We find in our practice, I'm not really sure if it's the same in the US, that we often need an adjuvant. And we find that we need a small dose of lorazepam or a very, very small dose of quetiapine just to give a bit of extra anxiolysis or calming. Do you find the same?
No. For opiates, for pain.
Yeah.
But not really for sedation.
Not really for anxiolysis.
Use much bigger doses, I think.
Do you really? What kind of doses do you use?
Probably average 1.5, 1.5.
Right, okay. Because our license dose is up 1.4, isn't it? So we get a bit nervous after that. But we have colleagues that...
Higher.
Sorry?
Many patients are, that would be the mean, like we have patients in 2.
No, okay.
They get hypertensive, actually.
Do they really? Is that some kind of reversal of the binding, do you think?
Perhaps the peripheral alpha effect versus the central.
No, I've gone back. Sorry about this. So, just to finish off, dexmedetomidine, very important addition to UK sedation and American worldwide sedation. It's at least as good as Propofol midazolam in the mild to moderate sedation. It's got some unique properties. This lack of respiratory depression is very appealing. It has some analgesic effects as well, and it holds an unrestricted license. Arousal sedation could change the way we manage patients in the ICU, particularly long-term patients, particularly those with a tracheostomy, I think, that one can communicate with. GSTT, we found a challenge in predicting those patients. I think what we do is we think, this patient's delirious, let's try dexmedetomidine, where we actually probably should have said, this patient might get delirious, let's try it a bit earlier. Patient groups have to be defined and redefined, and that's really because it is a very expensive therapy compared to others. So what we need for sedation is some kind of guideline, which we all agree. What we do at Guy's and Thomas is the intensivists, pharmacists, nurses go away. We agree a guideline, and then that's instituted for the vast majority of patients. So, in conclusion, what? I put it to you, Propofol plus an opiate is probably the best therapy for the short-term patients. Midazolam plus an opiate for the younger patient or those with single organ failure, those with respiratory failure, ARDS without any other organs involved. Opiate is up to your unit choice. We like fentanyl and alfentanyl. I know a lot of other units use morphine. We've just never got much success with it. Adjuvants, much more important in the long-term ventilated patient, and dexmedetomidine in specific patient groups, and agree your patient groups. When I define patient groups for sedation. Individual plans are needed for those difficult patients. And those very difficult patients, you've got to engage all the key players, liaison psychiatry, neurology, specialist pharmacists, and really that you need a daily plan, and that daily plan changes as the patient's organ function changes. Newer agents may mean a shift in therapy, and we might have we might see more, would like to see more arousal sedation. And why? Sedate, well, essentially because you need it. We can't do without it. It's an essential therapy in ventilation. How much? How much, Luigi? Is as little as one can get away with. And lastly, thanks to Luigi and Draeger for inviting me to speak today. Thank you.